to move on to our next speaker, J. Taylor Hayes. Dr. Hayes received his MD from Vanderbilt University in 1980, completed his internal medicine residency at Vanderbilt, and was a chief medical resident in 83 to 84. He has been a staff and faculty member at the Mayo Clinic Rochester since 1991. Currently, Dr. Hayes is a professor of medicine in the Mayo Clinic College of Medicine and Science, and he is the director of the Mayo Clinic Nicotine Dependence Center. Dr. Hayes holds board certification in internal medicine and addiction medicine, and is actively engaged in the practice of general internal medicine and provides clinical care for patients with tobacco dependence. His clinical research is focused on developing and testing pharmacologic and behavioral treatments for tobacco dependence. He has authored numerous peer-reviewed articles, abstracts, and book chapters on the treatment of tobacco use and dependence. I'd like to welcome Dr. Hayes.
Thanks, Kara. Is my audio okay?
Perfect.
And can you see my slide?
Yes.
Perfect.
Great.
So I really propose that the topic today would be, looking at the issue of harm reduction using electronic cigarettes. And I'm not here as an advocate for that, but I will say that I think we're gaining more knowledge, and we're going to have to start considering how this can be a tool we can use, as it is still one of the adversaries because of the lack of data. I have no disclosures, and this is what I hope to do. We'll look at harms of electronic cigarettes and look at the ideas surrounding harm reduction, some examples that are probably familiar to you, and then look at the evidence for and against it and apply that evidence at the end, hopefully. Although I don't think I'm going to come to a firm conclusion about telling you how we should view e-cigarettes. I have some opinions that I'll share. Just to level set, you all are quite familiar with electronic cigarettes. I'm going to use that term. Electronic nicotine delivery devices is another term, but that includes the heated tobacco products that Dr. Ebert just discussed, and we won't be discussing those. So the common theme behind all electronic cigarettes is that they contain a heating element that's powered by some sort of battery source. They contain a liquid-filled vessel, can be a refillable cartridge or a disposable cartridge, and that liquid is then wicked up to the heating element, and an aerosol is created that you can inhale. And as you all know, the devices have changed dramatically. In fact, it seems that almost daily there's a change. And this is some of the evolution from the cigarette-like or ciga-like devices to the devices that we have now that look nothing like a cigarette. Some of them are pin-shaped, some of them are box-shaped, but they have interchangeable parts with refillable tanks and with disposable tanks. And of course, nowadays we have pod devices that have a disposable cartridge that fits on the end of the power source, and that cartridge, in the case of the Juul device, which has become very commonly used among our youth, contains the heating element, the wicking material, and the liquid all in one. So with that as background, which I think you probably all were familiar with, so let's talk about what is harm reduction. Again, probably a concept that you're familiar with. This is the World Health Organization definition. Basically, what we're trying to do is decrease the harm from something known to be harmful, knowing that we can't eliminate it, that is the harm altogether. And in this case, it has to do with having people reduce or quit tobacco cigarettes, or substitute something that will reduce the harm from tobacco cigarettes for those people who are not able or unwilling to quit. Now, harm reduction is something you guys are familiar with. We drive cars. Cars are dangerous. To reduce the harm of driving, we have both passive and active restraints, and among the active restraints that we're all familiar with is the seatbelt. Most of our states have seatbelt laws for adults, older children, and child restraint devices for younger children. So we don't remove the harm of driving, we can reduce it. Similarly for bicycle helmets, reducing the harm of head injury, but it doesn't reduce entirely the risk of riding a bicycle, as many of you probably know if you've had accidents. And more closely aligned with medical harm reduction are harm reduction from opioid drugs, both licit and illicit, but mostly the illicit drugs. And so there are different approaches. I mean, this week there have been in the news ideas about safe injecting places. In San Francisco, there was one opened. Needle exchanges for clean needles to try to reduce the harm of bloodborne diseases. And then, of course, substitute opioids like buprenorphine, which, again, doesn't eliminate the harm from opioids, but eliminates many of the harmful effects of opioid use. So when we think about harm reduction for tobacco, we have to keep in mind what are the harms from tobacco. And again, you all are familiar with this. It is part and parcel of the 4 leading causes of death in the U.S. Cancer, especially aerodigestive cancers, heart disease and stroke, as well as chronic lung disease. And although this is an old estimate, honestly, the true estimate of tobacco-caused mortality in the U.S. is probably between 500 and 600,000 per year. So the FDA introduced a concept that I think is quite useful, and that is to think of tobacco and tobacco products on a continuum of risk, with the most harmful in this figure to the left, and that is the conventional combusted tobacco cigarette. And we just talked about the harms, which are manifold. And the least harmful approach is not using any tobacco at all, or nicotine replacement therapies, or other tobacco products. Now, where we place the various kinds of tobacco products that are probably less harmful than tobacco combusted cigarettes is uncertain. Smokeless tobacco, I just put on here as more toward the right. I think that's probably true. Just looking at the volume of morbidity and mortality related to smokeless. And where do we place electronic cigarettes? I think it's unknown, largely because we lack a lot of data that we need to be able to make that judgment. In 2018, Public Health England produced this white paper called Evidence Review of E-Cigarettes and Heated Tobacco Products, and they stated that vaping is 95% safer than smoking. And they were strongly urging smokers to switch to electronic cigarettes. Now, I don't know if 95% is the right number. There is little doubt that switching completely from tobacco cigarettes to a vaping device, an electronic cigarette, will dramatically reduce the harm, but it doesn't eliminate it. Dr. Ebert just made that point quite well about drowning in an ocean versus a bucket. But what we want to do is try to understand as best we can with the knowledge that we have today and the evidence that's available today is how much reduction in harm could we achieve? So first we need to look at the exposures. Dr. Ebert talked about this. He is one of the authors on this. This was a study done out of his aerosol particle lab. And they looked at the toxicants present in the aerosol. So this is not someone using it and looking at their exposure, but looking at the levels of toxicants. And I won't read each bullet point, but what they found was that there were multiple toxicants found. The magnitude of the level of toxicants was generally quite a bit lower than in tobacco cigarettes. And the other important thing is that the level of toxicants, as well as the chemical constituents of the e-cigarette liquid, changed with heating. And the more power you apply to the heating element, the more and different kinds of toxicants you may get. And the toxicity of the various chemicals in e-cigarette aerosols on human cells is largely unknown. Again, we are operating in a vacuum of evidence. This is just an example of a different study. Rather than looking at the actual constituents in the aerosol, we wanted to look at what was the exposure of an individual to certain chemicals. In this case, we're looking at NNAL, which is one of the tobacco-specific nitrosamines, which is known to be cancer-causing from the tobacco cigarettes. And what you see is urinary nicotine levels, so that if you use a cigarette only, dual cigarette NRT, dual cigarette and electronic cigarette, NRT only and electronic cigarette only, those are the categories. And when we look at nicotine exposure, you can see that e-cigarettes and cigarette only, if you just look at the two boxes, the one on the far left, one on the far right in the urinary cotinine panel, they're about the same. The mean nicotine levels was about the same. In other words, people can get a fair amount of nicotine from e-cigarettes, and that's why they are in many ways more satisfying for smokers than using NRT, where you see the mean nicotine level was quite low. And their exposure to NNAL, this tobacco-specific nitrosamine in the right-hand panel, was considerably lower if you used NRT, as we might expect, since there's no combustion at all, or electronic cigarettes only. Any use of tobacco cigarettes, whether it was dual with NRT or dual use with electronic cigarettes, caused the same exposure to this cancer-causing chemical. So this would tell us that two things: toxicant levels in e-cigarettes are lower, and the exposure of a person who only uses e-cigarettes to potentially cancer-causing chemicals seems to be lower as well. So here are some of the early conclusions that I reached: that we understand that tobacco, especially the combusted cigarette, causes the vast majority of harm. 7 million deaths a year in the world, 500,000 deaths a year in the United States. E-cigarettes have lower toxicant levels in them, and it appears that people who use e-cigarettes are exposed to far lower magnitude of these toxicants. Smokers find e-cigarettes more satisfying and acceptable as a substitute for cigarettes than NRT, and this is because they can get nicotine from them, as well as have the tactile response of having something in their hand and being able to puff on it. And the only way that smokers can really get the benefit, however, or reduce their harm, is if they make a complete change. And I'll show you more data regarding that in just a moment. So let's leave that for a moment, and let's look at the health harms from e-cigarettes as a comparison. And I'm just going to give you a few examples looking at both pulmonary and cardiovascular effects. First of all, the long-term adverse health effects, I say this over and over, are largely unknown. We are operating in a vacuum of data and long-term follow-up. E-cigarettes have been around and used since 2007, but in the United States, really commonly used since about 2010, 2011. So we only have about a decade where we've been able to follow people. The devices are changing rapidly, as are the solutions. And so what we studied 5 years ago is not what people are using today, and that confounds us. And then that last point I make here is that recall that it took us about 50 years to finally catch up to the tobacco industry and where they were with both the sophistication of their product and the harms that it caused. In 1964 was the first Surgeon General's report, and people in the United States started using the modern tobacco cigarette in great numbers in the early 1900s. So we're a bit behind the 8 ball here. When we look at cigarettes and lung toxicity, there are a number of compounds in e-cigarette aerosols that are likely to cause harm to lungs, and I've listed them here. And of course, the last bullet there, the unknown additives, and we learned in spades in 2019 what vitamin E acetate can do as an additive. It seems like eons ago, doesn't it, that we had the EVALI epidemic, because it was waning just as the current COVID epidemic was starting. But it was quite something, and it was in the news every single day. And so we know from this experience in 2019 that there are chemicals in e-cigarette aerosols that can cause significant and sometimes fatal harm to lung function. About 20% of the people who had documented EVALI indicated that they had never used THC-containing liquids, and those were the liquids that contained the vitamin E acetate. So it still leaves open this question that perhaps some people can have serious lung injury from nicotine-containing solutions, and we, of course, don't know what adulterants or additives might have been in there. And then these are some of the observed effects in studies, and I didn't provide examples here just for the sake of time, and I've summarized them. But you can see measurable impacts on reducing lung function, on spirometry, airflows, biomarkers of airway inflammation increase. There is delayed recovery from respiratory infection. And in vitro studies, there is direct toxicity of many of the chemicals that we find in e-cigarette aerosols on human cells. However, those studies have not been done in vivo. So there is clearly an opportunity for serious lung injury, and the Valley epidemic showed us just how serious it could be. Although with typical e-cigarettes, we are not seeing the kind of lung injuries we were seeing during the Valley epidemic. Regarding cardiovascular impacts, I've listed some of them here. It does reduce endothelial function, causes more vascular stiffness, platelet adhesion, more vasoconstriction, and increases heart rate and blood pressure. So it increases oxygen demand, and there are a number of things that it does that might decrease the oxygen delivery, and that might set us up for heart disease. This is an observational study from the Behavioral Risk Factor Surveillance Study, and you can see that this looks at, if you look at the graph, people who, the negatives are never used e-cigarettes, positive is they did use e-cigarette, and then the two categories are never used combustible tobacco, or on the far right hand, current combustible tobacco user. You can see that if you used combustible tobacco, your odds of having cardiovascular disease, and this is a composite outcome, heart attack, acute coronary syndrome, requiring revascularization for coronary disease, so and a number of other diagnoses, as you can see, that those composite outcomes were much greater in people who used combusted tobacco. If you either never used e-cigarettes and never used tobacco, or never used tobacco but did use e-cigarettes, you can see that the odds of having cardiovascular disease in this observational study were the same as those people who didn't use either e-cigarettes or tobacco. So it says to me that there probably is a reduced harm of cardiovascular disease if you only used e-cigarettes and never used combusted tobacco. This is a laboratory study showing that, or measuring rather, the forearm flow-mediated dilation. So I won't go through what they do here, but the normal response is an increase in the dilation of the vessel and more flow. And so the two right-hand panels, e-cigarettes with nicotine, e-cigarettes without nicotine, that's a normal response. People who used cigarettes in the far left-hand panel had no increase. And this is a measure of endothelial dysfunction. So this laboratory study also suggests that people who use cigarettes have marked endothelial dysfunction, as measured by this flow-mediated dilation. People who used e-cigarettes with or without nicotine did not seem to have any endothelial dysfunction. Again, suggesting that cardiovascular harms should be reduced with e-cigarettes if only e-cigarettes are used. There are many, many more studies, some that are more mixed in their outcomes, but I wanted to illustrate that I think the general consensus is that cardiovascular risks are lower with e-cigarettes compared with combusted tobacco. Now let's look at the data on whether people stop smoking cigarettes if they use e-cigarettes. There are two studies I'm going to show you from the PATH study. I'm not going to go through this figure in detail. It's kind of complicated, but generally it's 3 waves of survey. Wave 1 you can see is 2013-14, wave 2 the next year, and wave 3 was 2015 and 16. And so what they were looking at in this study was people who were daily smokers when they entered wave 1, but who had a quit attempt before wave 2. And then they're asking them, how did you quit? What did you use to quit? And this is the outcome. The cessation aids most commonly used among smokers was nothing, which is unfortunate because, as we know, that using nothing is probably the least effective way to try to quit. E-cigarettes were used by almost 24%, pharmacotherapy, NRTs primarily used by slightly under 20%. And you can see that the abstinence outcomes at wave 3, people who were abstinent for 30 or more days or up to a year, it didn't matter which they used, whether it was cold turkey, pharmacotherapy, or e-cigarettes, they all had about the same kinds of outcomes, suggesting that people commonly use e-cigarettes to quit, and they, at least in this survey, seem to work. This is a randomized trial that was published in 2019, and they randomly assigned people to the nicotine replacement therapy of choice versus a standard e-cigarette. They used, in this case, blue as their e-cigarette. And for the outcome, the main thing I want you to look at is right there under that red line. The primary outcome was abstinence at 1 year. And you can see that in the primary analysis, that this column here, second from the right, the odds of abstinence at 1 year with e-cigarettes versus nicotine replacement therapy was 1.83, and that was a significant interval. And so it did appear in this study that e-cigarettes were more effective than nicotine replacement therapy, and they had some brief behavioral therapy for quitting tobacco. I will say that at the end of a year, about 10% of people were still using the NRT, and over 60% of the people were still using their e-cigarettes. So they were using e-cigarettes long term, no doubt. So in this study, e-cigarettes were more effective than NRT for smoking cessation when they also got some brief behavioral support. And then I just present here the most recent meta-analysis looking at e-cigarettes for smoking cessation. And you can see that the point estimate is 1.69 for quitting tobacco when comparing e-cigarettes to NRT. So in the meta-analysis, e-cigarettes appear to be more effective than NRT in helping people quit tobacco cigarettes. And it seems to be that nicotine e-cigarettes were more effective, as you might imagine. And there were no important differences between e-cigarettes and NRT in adverse event outcomes. Lastly, I'm just going to show you this. I thought this was an important recent study. This also comes from that PATH survey, those 3 waves. And they were looking at people who quit cigarettes who had no intention or plan to quit, and based on whether or not they used e-cigarettes during the follow-up period at wave 2 and wave 3. And I just want you to pay attention to this very bottom row, daily e-cigarette use. If you go over to the far right, the odds of discontinuing daily cigarette smoking at follow-up at wave 3 was a point estimate of almost 9.7 in a significant interval. So people who did use e-cigarettes daily, even if they weren't intending to quit smoking cigarettes, did either reduce or completely quit tobacco cigarettes. And so the observational data suggests that people do want to use e-cigarettes to quit, and some people, even if they're not intending to quit, if they switch to e-cigarettes, may be quitting. So e-cigarettes for smoking cessation, these are the conclusions. They may be as good as NRT. I think the data is still somewhat limited, and it's hard to say that definitively. Nicotine-containing e-cigarettes work better. No surprise there. Daily e-cigarette use may help people stop smoking who aren't really intending to, but they're trying to make the switch. And the evidence for basing clinical advice to use e-cigarettes for smoking cessation is quite limited. We do not advise at the Mayo Nicotine Dependence Center people to use e-cigarettes for quitting. We advise them to use the medications plus behavioral therapy that we know is proven to be safe and effective. However, as we accumulate more data, we may learn that there are some ways we can use e-cigarettes to our advantage to help people quit tobacco cigarettes, even if they aren't able to quit e-cigarettes entirely. So this, again, would be a harm reduction approach. So how do we apply this? We have to put it in the balance, right? I mean, and I've just presented you very limited data, and however, I don't think I'm presenting a distorted picture. I think what I've shown you is probably where we are in terms of our data today. So how do we put this in the balance and weigh it? And the first caveat I'd say is we as clinicians, and I'm a clinician as are most of you, I think, and public health experts, we have a different view of things. So when a public health expert says, gosh, it makes perfect sense to promote the use of e-cigarettes or other reduced exposure, modified risk tobacco products, MRTPs, that Dr. Ebert was talking about, so the heated tobacco products. It makes perfect sense for us to encourage our people, let's say in the US, to make this switch. Start using these electronic products and stop using your tobacco cigarettes. Because we know if we do that, that people will reduce their exposure to tobacco, and that will likely reduce their risk of disease and adverse health effects. However, we as clinicians, we don't deal with the public. We don't deal with 350 million people. When we are managing patients, we are dealing one-on-one with a patient who's asking us our advice based on best evidence and our best judgment. We have a fiduciary responsibility to that patient to provide them the best, safest treatment. And for smoking cessation or for reducing the harms from tobacco, we are still at the point of saying, my advice is that you should quit all tobacco use and that you should use what we know is safe and effective, combined pharmacotherapy with behavioral therapy. And that's where I land. But I think it's important to understand that we speak different languages in the public health realm versus the clinical realm when we're with patients. And that's where a lot of the public arguments come from. So in terms of application to your practice, I'd say no doubt, strong, long-term evidence that pharmacotherapy plus behavioral therapy is the safest and most effective way to help people quit smoking. We have decades of data and many meta-analyses of pharmacotherapy, behavioral therapy, and their combination to know that it works, and it works in every population where we try it. I'd say that the evidence right now for e-cigarettes for helping people quit smoking is weak to modest. We need more studies, and we need other methodological approaches. We're basing a lot of our discussion now on mostly observational data. So we need randomized controlled trials similar to the one I showed you, but we need more of them to replicate the data from that study and to use modern electronic cigarettes. We need long-term health impact information about e-cigarettes. As I said, I mean, only commonly used in the US for about the last decade. And it took us 50 years to finally understand the long-term health impacts of smoking combusted cigarettes. So we need more data about the long-term health impacts of e-cigarettes because it remains largely unknown. And how can we judge if we don't have that information? The last thing I'd say is if anyone is going to gain any benefit from an e-cigarette to reduce the harm from smoking, the only way to do it is not to use tobacco cigarettes at all. They must completely switch over. And if there's any benefit to be gained, that's the only way it will happen. I was a co-author with a couple of good friends and colleagues of mine, Tom Glenn and Katie Kemper, and this was published in Mayo Clinic Proceedings last spring. If you have a chance, you pick it up and read it. It's a quick read. We wrote an editorial about this whole issue of public health and clinicians, the different sides that they take, and it sometimes seems that we are really adversaries when we are not. We're on the same team. But I think the main thing the editorial says is we need more data on adverse health impacts of e-cigarettes, especially the modern products, more data on how we can help patients to use these products, quit smoking, and if they do quit smoking using these products, is it safe and effective? Long-term follow-up. And lastly, we need a much stronger regulatory system to keep youth from using and allow adults to use safe e-cigarette products to help them quit combusted tobacco use. And so I encourage you, if you're interested in this debate, to pick up that editorial and give it a read. So to conclude, where do we put e-cigarettes on the continuum of risk? I put the question mark there because it's still unknown. I think are going to reach a point in the next decade where we'll have much better data to be able to place it on this continuum of risk. And if we find that there are products that are very helpful at reducing the harms of combusted tobacco, maybe even helping us eliminate the use of combusted tobacco, we may be saying something quite different. But today, we still don't know. And so what we advise our patients to do is to use what we know is safe and effective. And I thank you for your attention.
Thank you, Dr. Hayes. You're just perfect on time. I appreciate it. I think you've brought up a lot of good points. So thank you for your in-depth look at ends and the pros and cons. I really appreciate it. Thank you again for joining us.